Hypercalcemia is a very commonly encountered problem in our clinical practice. The diagnosis is often made incidentally. The most common causes of hypercalcemia are primary hyperparathyroidism and malignancy. Diagnostic workup includes measurement of serum calcium, intact parathyroid hormone also called IPTH, and history of any medications being consumed by the patient. Hypercalcemic crisis is a life-threatening emergency. The most important issues in hypercalcemia are: it is most often asymptomatic. It is an incidental diagnosis when we do routine screening of blood for serum calcium. Mild hypercalcemia may remain asymptomatic throughout life. Most important cause of hypercalcemia, remember, is hyperparathyroidism. Differential diagnosis is indeed essential to decide the nature of treatment. Optimal step-by-step evaluation is a must, which we will present in our presentation in this particular CME. 98% of our calcium in the body is in the skeleton, in the bony part of our body, the skeleton. Only 2% of the calcium is in circulation, and about half of that is the free calcium, also called the ionized calcium. This ionized calcium is the one which is physiologically active across the cell membranes, and remainder 1% of the calcium in the serum is bound to the plasma proteins. Direct measurement of free calcium, though, is more accurate, is difficult to conduct, and also not available routinely in all the laboratories. With the result, we measure the total calcium and use it as a proxy for the free calcium. Remember, calcium levels in the blood are maintained in a relatively very narrow range, and this is what is called the calcium homeostasis. Three important hormones play this role. The PTH, also known as parathyroid hormone, and then of course the active form of vitamin D3, which is 125 dihydroxycholecalciferol or 125 DHC. This is also known as calcitriol, and of course the third hormone is the calcitonin. So the homeostasis of calcium is dependent mainly on parathyroid hormone, vitamin D3 and calcitonin. This homeostasis of calcium is maintained by these three hormones by their action on the three regions in the body. If the serum calcium were to be increased, there will be increase in the bone resorption, there will be increase in the intestinal absorption, and there will be decrease in the renal excretion. If the serum calcium were to be decreased from a higher level to normal level, then bone resorption will be stopped, intestinal absorption will be reduced, and renal excretion will be prevented. These three hormones together act with different feedback loops such that the calcium levels are maintained within a very narrow acceptable normal range. By the processes of bone resorption, intestinal absorption, and renal excretion. Look at carefully this diagram. Normally we have a calcium intake of about 1000 milligrams or 1 gram of calcium through our GI tract. This enters the gut, and of which 900 milligrams is excreted in the feces. Only 100 milligrams is absorbed in the net. That means 350 milligrams of calcium is absorbed and 250 milligrams of calcium is secreted into the gut. So the net absorption being 100 milligrams from this 1000 and 900 being excreted. So to the 350 milligrams per day that is absorbed, that enters the extracellular fluid, which is in equilibrium with the calcium in the cells, which is 13,000 milligrams. And this extracellular fluid is again in balance with the bone, which contains as much as 1 million milligrams of calcium molecules in the bone. 500 milligrams of calcium is deposited in the bone every day, and 500 milligrams of calcium is reabsorbed. This is the process of bone remodeling that occurs every day. So, from the 1300 milligrams that is in the extracellular fluid, 9980 milligrams is filtered by the kidney and 9880 milligrams is excreted back into the system by reabsorption. So, the net excretion by the kidney is 100 milligrams. So, out of the 1000 milligrams that we take in, 900 is excreted in the feces, 100 is lost in the urine. That is how the calcium homeostasis is being maintained. How these three important hormones control the serum calcium levels? You can see in this table the various hormones, the parathyroid hormone, the vitamin D3 which is the active form of vitamin D, and the calcitonin. The effect on the region of the body, the bone, the gut or the kidney. Parathyroid hormone, the effect is in nutshell, it increases the calcium in the body, it increases the calcium in the serum, it decreases the phosphate in the serum. An increase in the calcium and a decrease in the phosphate is facilitated by an increased activity of the osteoclasts in the bone. Indirectly, it acts via the vitamin D in the gut to achieve this, and also on the kidney, calcium reabsorption is facilitated and phosphate excretion is increased by parathyroid hormone. Whereas vitamin D3, the net effect is increase in the serum calcium, increase in the serum phosphate. There is no direct action of vitamin D3 on the bone, but of course vitamin D3 has got a profound action on the calcium receptors in the GI tract, wherein it facilitates the absorption of calcium and together with phosphate in the GI tract, particularly from the small intestine. It has no direct effect on the kidney. Whereas the calcitonin, the net effect is decrease in the calcium, decrease in the phosphate, an action which is completely opposite to the action of vitamin D3. It inhibits the osteoclasts at the bone. It has got no direct effect on the gut. Of course, it increases the excretion of calcium and phosphate at the level of the intestinal tract. Look here, the boxes marked yellow. Here, parathyroid hormone, the major activity is in the bone by increasing the osteoclastic activity. For vitamin D3, the major activity is at the level of the gut by increasing the calcium and phosphate reabsorption through the calcium receptors. Whereas for the calcitonin, the major action is at the level of the kidney by facilitating the excretion of both calcium and phosphate. These three hormones in this way maintain the calcium homeostasis.